The last session of those 2 days, it will be the recap of our last implementation and embedding new therapies technologies session, and it will be delivered by Professor Elizabeth Davies, who is pediatric endocrinologist. She's also head of the Department of Endocrinology in the Perth Children's Hospital and co-director of the Children's Diabetes Centre.
Thanks, Dorota. And that was a great panel, actually, because it really brought together some of the themes that I think ran through the preceding 7 speakers, I think they were, which I was sitting there going, wow, how am I going to wrap this up and tie them together? So thank you to Elif and the panel. I think you've done that. And can I move these slides? Okay, so at the end of yesterday afternoon, I was struck by the fact that what's been very far on the horizon for many of us clinicians and when we're talking to our patients, which is the reality of prevention and intervention, was perhaps coming a little closer. And in fact, if I could have got this video to work, you would have seen this big whale coming out of that ocean up there and the Kimberley coming towards us, which I think is an example of perhaps the acceleration, the speed in which we're moving towards some of these things becoming a reality. So that was a lot of yesterday. But also, as we finished yesterday, I was starting to think, wow, is the sun setting on all the work and some of the many thoughts we have about how do we improve the technology and the therapeutics for our patient. But I think the last session today was a strong reminder of the importance of maintaining our work and our research and our commitment to people living with diabetes and our efforts to improve the lives of every single one of those. But secondly, the session from today, I think, for me was a reminder, how do we make sure we learn from all of the work we've done over the many, many years in developing whether models of care, technology, insulin, trials, whatever it is, and take that and use that and apply it to many of the exciting discussions we had yesterday. So I've tried to pull some of those pieces out of my wrap-up. And I think Mary said this young lad's name was Zeph, but I wanted to start by thinking this session was no different, or reminding you to any of the other sessions that JDRF have put together over the last 2 days, reminding us that how important the voice of the community is and that it's been woven through all of the sessions and the meeting over the last 2 days. And for anyone who knows me, they wouldn't find it any surprise that there's a typo on that slide when I have to type quickly and don't check what I'm doing. So just quickly, I'm going to run through, and what I kind of did was try and pull out a few pieces and then put my thoughts in there. And so I think Jeffrey actually just had to leave. I saw him go down the back. I think Jeffrey said he's got the biggest lab or the biggest team of any of us, the whole health system. And I think that is actually summarises some of the challenges of that, the pointy end of getting the work and the studies and the trials actually into practice. And he made a very important point that he taught us several years ago when we first met and started to collaborate with Jeffrey, which resonates with me all the time. It takes 17 years to get 14% of outcomes into clinical practice. So we need to keep that in mind in all of our discussions. How do we make sure, if we think the work that we're doing is important, that more, that it gets there? Actually, it's not part of the 86% that gets dropped, and it gets there more quickly than 17 years. You made it very clear that healthcare is a complex space and gave us some thoughts about the next 10 years, which were very interesting and helpful in terms of where we're going. But I think perhaps the other message was that the system needs to be, we need to be more lined up and better linked and more patient-orientated in the way that we're doing our work. And I'm not going to go through more detail. You all sat and listened to his excellent talk. For me, the value of the talk and perhaps the takeaway message is the importance of bringing experts into the work that we do who are experts in disciplines outside diabetes. So often we meet and we see our colleagues and our friends when we get together at these meetings, but one of the things I think Jeffrey highlighted, and has certainly been a learning for me over the last few years, is how we can value add and accelerate our knowledge and our plans when we bring people with fantastic expertise outside of diabetes into the diabetes world. And I also thought that one of the takeaway messages from Jeffrey's talk was we need to not lose sight of our goal. Our goal is to improve the lives of people living with diabetes, not ourselves, not 100,000 papers, and the health system doesn't always align their goal with that goal, and that's a challenge for us. And the other takeaway message, I think, from that session was the value of learning from other conditions, and we also heard that yesterday with the discussion, particularly from in the rheumatology space. So a session recap, boy, it was talk about pivoting and turning in different directions, but anyway. So Mark gave us a lovely overview of adjunct treatments, together with obviously insulin type 1 diabetes. And I think one of his messages there was absolutely glycemic control has been much more accessible and easier to achieve with the new technologies and therapeutics. But for both people living with diabetes and for those of us who are clinicians or delivering healthcare, we need to start thinking outside that glucose lens as we get better and better there, and that there are now there's new evidence that there are other therapies in particular that can help make it, I suppose, contribute to that holy grail or that long-term lens of a life for someone living with diabetes with no complications. And so he gave us some lovely examples of some of those new therapies coming in, and I won't take you through all of those because you've done that so beautifully. For me, the takeaway in his session, and I must apologise just for the words on here, I would have failed Avani's Pekachucha session or whatever it was called because I only had time to type and no beautiful pictures here. One of those takeaway messages, for me, was one of the studies he talked about, which was the value of real-world data. And I think that came up again later in the sessions and in the panel. We mustn't focus only on trials. We must focus and learn from actually what happens when we put those trials into place. And that's when all the questions about well, I'll come to it, but equity and subgroups and minority groups and how well does it actually work and reach all of those people that we care for, not just those who put up their hands to be in trials. And Lenny made I thought an important point yesterday. I don't know if she's still in the room, but that she said the US have insisted that 10 years of data follow-up is important for the I've been a mind blank, but the regulatory approval of teplizumab in the States for stage 2 diabetes. And I think for me that resonated really importantly, that's something we need to take aboard and think about. And we need to organise ourselves. How are we going to set ourselves up, whether it's regulated upon us or not, to follow the real-world outcomes of not only teplizumab, but any of the other new therapies that come in? We're beautifully well coordinated. We could set ourselves to do that incredibly well, but we should start to be getting ourselves organised to do that now. So whether it's for adjunct therapies, interventions, preventions, and even some of the technologies we're using now, I think we could really value add to that space. So that needs a life course lens. The paediatricians need to talk to the adult physicians. The paediatric researchers need to talk to the adult researchers, and that's exactly what JDRF have pulled together here over the last 2 days. So Sybil gave us an absolute tour de force of all the updates in the technology, and particularly the CGM and pump data, and I won't take you through all of that again, obviously. Exercise, I'm a fan of exercise. We heard about exercise perhaps even as an intervention yesterday, but it's a double-edged sword. It's good for you, but it's challenging if you're somebody living with diabetes. And I think one of the other important messages from Sybil was that it's not a one-size-fits-all approach, and it's really important, and I probably haven't used the right lingo here, but it's really important that we think outside the square with every patient we meet, because it's individualising the care, and what that individual wants to manage their diabetes is the crucial pathway, and that came up in the panel. And can't remember what I meant when I wrote down that she presented equivalent real-world outcomes. Anyway, we'll move on from that. My takeaway message there was the CGM subsidy was indeed a great win in Australia, and this came up again in the panel, but there is a huge current inequity of access to pumps, and I won't say any more because I think you could feel the emotion in the room. It's a key area for us to tackle in diabetes. People with diabetes actually have an excellent track record of adoption of therapies or being early adopters, and you talked about the open loop, and I thought that's something we should be constantly reminded of. People with diabetes adopt things so much more readily than we do, and the healthcare system does. But I did think it was fair to say that clinicians in diabetes, I actually think, have a reasonably good track record of early adoption. I thought that's some optimism for the intervention and prevention horizon. When you look back, we've been pushed by people with diabetes, but actually, and I think Australia's a good example, we have taken on those changes relatively well. So I felt some hope there. And as a paediatrician listening to Sybil's talk, I thought it was a reminder to all of us, again, as I said, to have a life course lens in the way that we plan diabetes care and management in this country. Trials, we'll come back to trials because it came up in the panel, but the question was, do we need to move beyond the traditional design They're slow, they're expensive, and they never give you, well, currently many of them that have been done haven't given us all the outcomes we want. And Jane had a lot to say in her presentation about that as well, how we could value add and improve those. And this ties in with this question here, a challenge I took from Sybil's talk. As the new technology pipeline moves along, we need to evaluate not only the outcomes, but also the equity of access to all. You can break that down in as many ways as you want in terms of quintiles of socioeconomic situation, rural versus regional, cultural differences, ethnic differences, however you want to look at that, language differences. But we certainly need to start to do that better in everything we design. Tim Jones presented on sort of the translation and what have we learnt, and certainly gave a really lovely, clear demonstration, which is a really nice thing to remember, that outcomes in type 1 diabetes have improved, and we should be stopping and celebrating that. But in fact, outcomes are impacted by more than therapy, and that's where it ties in with the translation and models of care that we deliver. Equity and implementation, same theme coming up again, should be integral to the trials and the interventions that we develop or that we implement and consider doing. Again, coming back to that, we need to change the way our mindset is when we develop trials or interventions. We've been using very traditional models of care, and we need to start thinking outside the square and how else we can deliver diabetes care and new models of care. The social determinants of health are not always well understood, which I think he touched on, but I'll come to Louise, who demonstrated that so beautifully in the type 2 space. And the barriers and enablers differ in different jurisdictions. So I think my takeaway learnings from that is iPhone deficiency is clearly a better problem to have than insulin deficiency, because you get your answer a lot quicker. It's important to celebrate the successes. I think I touched on that earlier. Data is critical, and I'm going to come back to data at the end, but Tim did touch on this. It's really important to be able to look back at what you've done, and it's really important to have really comprehensive data looking forwards at where you're going. And so as a community, we have to look at how can we collect that right data, how can we be sharing it, how can we be using it to the best advantage of the people whose data it is, the people living with diabetes. Well, it comes back to the same theme. As researchers and clinicians, we must remember all people living with diabetes, not just the loudest voices and not just those who put up their hands to join our trials. Now, Louise gave a beautiful talk on many of the challenges, and I think only just tipped on the iceberg of the wonderful work that her team have been doing in the Northern Territory to improve outcomes, not only the Northern Territory, across Australia, of people living mainly with type 2, mainly Aboriginal people, but probably extending, I imagine, to care of all people with diabetes in the Northern Territory. And I think brought a reality check with a couple of those clinical conundrums. Some people say, oh, the difference between type 1 and type 2 is like this, but all of us have faced that question in our clinic now of trying to make that difference between type 1 and type 2. And a consistent feature of disadvantage and poverty, which she demonstrated so clearly. Food insecurity, one of the things she mentioned, but there were many others as well. And a constant reminder to us, these are not just features of people living with type 2, but many of our families who also live with type 1. It was a very sobering statement. Diabetes is a leading cause of death in the Northern Territory. She highlighted some things that are really similar to those for all those delivering care to people, whether they have type 1 or type 2 diabetes. We've all got challenges with staff, with resources and technology. They are greater and steeper and harder to solve in rural and regional areas. And as clinicians, many of us based in big tertiary centres, we need to remember that as part of our advocacy in our conversations with healthcare delivery. How do we make sure we get equitable access for everybody? And the value of incorporating cultural knowledge into care models. And I think, Louise and her team have done that just absolutely par excellence, and have got so much to teach the rest of us about how to do that well. So my takeaway messages, perhaps for all of us, are that the social determinants of health are leading to greater disparity in access as time is going by. They're not lessening. They're not getting smaller, the gaps in access, clinical care and outcomes for minoritised public populations. There's clearly tension between resource allocations, and I could almost see some people sitting up and getting a bit twitchy when Louise started to stand up and talk about type 2 in a JDRF meeting with about type 1, but I think that's the reality, and it's fabulous to have these conversations. There is a tension. Where do resources go? How do we share them? And Jeffrey touched on that, as did Josh in his talk about, there's some difficult conversations that have to be had. How do we prioritise and how do we use our resources efficiently? I talked about her examples of community and team already. And I think the value of patient stories, which Louise demonstrated and which is something JDRF do incredibly well. So then Josh changed track again and we went to health economics, which is clearly a theme that's relevant to everything we've talked about today, and reminded us of the difficult choices we have to make, efficiency and opportunity cost. He used a lot of lingo that probably many of us are not familiar with, but feel, I think, again, a great example of bringing people who are experts in other disciplines into our space, into the diabetes space, and helping us with our work, that we can achieve so much more. He put up a flow of funding health figure that reminded me of all the immunology diagrams and figures I saw yesterday that I didn't understand and need to pore over more closely, and likewise his health funding figure, and it probably sadly it probably doesn't change very regularly, but it shows there's a whole lot of new stuff for us to be thinking out there. I think this figure is an important one to remember, that came out of the JDRF report, but that 19% of the total cost of diabetes is picked up by the government, and just what an enormous burden in both financial and other ways that rests with the people or people living with diabetes, and actually for many of you who are clinicians and healthcare providers in the room as well. Talked about some standard tools, and I wanted to pick up on his comment. I don't know if I've taken it exactly as it was, but modelling is only as good as the data used, and that just brings me back to a recurrent theme about the data that we have and our responsibility to be collecting really good data. For me, the takeaway was it was a bit of a reality check. The diabetes community doesn't want to just go window shopping and look at what they'd like to buy and like to have, because that's the when we sit in a room and pontificate about it, it'd be great to have this and it'd be great to do that. That's not what people with diabetes want. They want to actually go into the shop and they want to actually be able to buy and purchase or actually hold and have the therapy options that they choose. So we do need to be pragmatic and realistic. He highlighted important, how do we in my mind, a takeaway message is how do we tease out the value to the person living with diabetes versus the value to the clinical team versus the value of the payer and the government. And the conversations we can't shy away from. We need to work how to have those conversations together so we come up with the best solution. And I've already touched on data. I can't reiterate how important it is. And then Jane wrapped up with a beautiful overview of just how important it is that we remember the person as a whole, and the future of health versus my life now. And certainly those of us who work with adolescents and young adults and have children of our own who've been that age or are going to be that age, this is very real, isn't it? Today is important, next week's not that important, and 5 years' time's not important, and I'm never going to be as old as you, is their kind of comment. So that it's really important, the challenge of what we see as important and what they see as important. The quality of life is subjective, it's dynamic and it's multidimensional, and what's important to me isn't important to you, and what's important to me isn't important to my children's, and what is important to you isn't important to your physician necessarily. So we need to understand what's important to each person. And psychosocial studies are often the poor cousin, I say, was a message from Jane that came out there, and that's something perhaps we need to redress. She clearly gave some lovely examples of the global collaborations, and I think that's a really nice reminder of the importance and how well placed we are in Australia to actually engage in global collaborations, and we can actually make bigger and faster leaps that way. Open APS is an example that Sybil had already touched on, but the power of the patient, and so we must never forget that. And obviously she covered stigma well and how important it is, and the influence on decisions, and how well do we as care teams understand this. But for me, I suppose the takeaway message there is that diabetes is tough. Better design of trials and outcomes may help accelerate translation and implementation of findings. So we don't do a trial and then we add in these outcomes in the second round or the third round of trial. We design our trials properly and do them from the beginning. The importance of the person as a whole and the patient choice about therapy. And that early adopters can help take the rest of the group on a journey, and this is coming back to the open loop community that Sybil also touched on. So in my mind, I think my learnings were a little bit around the importance of transdisciplinary research, and JDRF have really exemplified that over the last 2 days, bringing people from many different backgrounds into the field. And I've just kind of added to this afternoon, but the concept of just how important all the different people being in the agenda are for these discussions. And I would take that one step further, that when we're designing a study, when we're designing an intervention, a trial, a research program, that each and every one of these people, if we get it right from the beginning, mean that the opportunity to do good translation and implementation will be accelerated. And the lessons learnt over the session relevant to the last 2 days, I think they're reminded that there are many people living with diabetes where prevention and intervention is not their solution. There are hundreds and thousands of publications in our research space and many advances in diabetes care, which is fantastic. There are many outcome measures to consider, so it can be challenging when we're designing trials and getting it right. And to get better care to more people, the following things are very, very important. A transdisciplinary approach, which without doubt includes people living with diabetes. They were one of the circles on the chart there, and they absolutely need to be front and centre partners in everything that we do. We need to build an implementation plan into everything we're thinking about doing. Every question we're asking, why are we asking it? If we find an outcome, how are we going to use that outcome? If there's an outcome that needs to be implemented, do we have a pathway to do that? We need to strengthen our networks. We need to put an economic lens over everything we're thinking about. And we need to have an advocacy plan in parallel if we're planning to influence government. So just coming back to Zeph, the voice of the community has been woven really beautifully throughout the meeting. It's been a privilege and an appropriate expectation, I think, that the people in the room, the scientists, the clinicians, the researchers and the clinical teams who are hoping to help people living with diabetes, to have them here as part of that conversation. And I would just summarise everything with co-design, co-design, co-design. And I know that usually means just have your consumers or whatever in the journey, but I would say it's all those other disciplines around as well. We do so much better. And I couldn't take a photo of our panel because I had to give them some slides beforehand. So there's the previous panel. But working together is so much more powerful than working in isolation. I think this last session highlighted not only the wide breadth and range of work that's happening here in Australia, but also many gaps that we still have to fill. And I'd like to thank, on behalf of everybody here, JDRF for bringing us all together for what's really been a fabulous and I think very important and productive 2 days. So thank you.